A patient with end-stage renal disease presents with a sudden onset of speech apraxia and a severe microcytic anemia. Following standard clinical protocols, the team administers high-dose intravenous iron. The treatment fails to raise the red blood cell count. Increasing the iron supply does not resolve the deficit. The underlying metabolic machinery is unresponsive, suggesting the assembly line has been stopped by a force that more iron cannot influence. This is the work of aluminum. It functions as a passive, invisible architectural saboteur, integrating into the body's structural frameworks and disrupting them by its mere presence rather than through active corrosion. This metal makes up roughly 8% of the Earth's crust. It is the most abundant metal on the planet. Yet primordial life evolved while environmental aluminum was securely locked within insoluble aluminosilicate minerals at a neutral pH. For billions of years, biological systems simply never encountered it in a bioavailable form. As a result, human cellular architecture never developed any dedicated homeostatic machinery to retrieve, transport, or safely sequester this element. Because aluminum has zero essential biological function, its presence in human tissue represents a pure xenobiotic intrusion. The ideal homeostatic baseline is absolute zero. Trivalent aluminum, an ion with a positive 3 charge, enters the body and bypasses cellular defenses through metallomimicry. The mimicry is physical. Aluminum possesses the identical charge profile and nearly the exact ionic radius as ferric iron. Because the dimensions match, aluminum slips into cellular receptors meant for iron. Once bound, aluminum exhibits kinetic inertness. Its high hydration energy causes water molecules to cluster around the ion with extreme force, creating a highly stable complex. When aluminum binds to ATP, it forms a complex with a dissociation rate 100,000 times slower than magnesium, creating a permanent chemical blockade that jams the enzymatic gear. This localized blockade completely halts the phosphotransfer cascades, effectively disabling cellular energy utilization at the site of the encounter. Aluminum establishes its presence by occupying essential metabolic positions and refusing to leave. It transforms active cellular enzymes into inert, immovable structures. In healthy individuals, the total body burden of aluminum is estimated at just 30 to 50 milligrams. The metal is heavily compartmentalized. Roughly 60% is held in the mineralized skeletal vault, while 15% is typically found in the lungs, derived from the inhalation of ambient dust. This low burden is maintained by the gastrointestinal tract, which normally serves as a strict barrier, blocking over 99.7% of ingested dietary aluminum. The citrate acceleration shift compromises this barrier. Citric acid converts insoluble aluminum into a highly soluble complex, increasing absorption 50-fold. This toxic flood travels to the kidneys, the master valve for clearance. But if the glomerular filtration rate drops, this crucial valve fails. This makes patients with advanced stage 4 or 5 chronic kidney disease the primary at-risk population. They have lost the gateway required to prevent systemic accumulation. Premature infants are similarly vulnerable. Their naturally immature kidneys cannot clear the aluminum that leaches into total parenteral nutrition fluids from glass storage vials. Clinical toxicity is rarely just a matter of exposure. It is a mathematical failure where intake exceeds an irreversibly broken clearance system. Aluminum navigates the vascular system by hijacking the protein transferrin, occupying the vacant spots normally reserved for iron. This transferrin nexus allows the metal to utilize iron receptors to bypass the restricted blood-brain barrier. This infiltration can lead to dialysis encephalopathy. Symptoms begin with speech apraxia and myoclonic twitches, often progressing to a devastating dementia. Simultaneously, the metal targets the skeletal system, driving a condition known as adynamic bone disease. Aluminum physically coats the bone mineralization front, blocking vital hydroxyapatite crystals from precipitating. It suppresses osteoblast activity, leaving the bone soft and prone to fractures. Finally, aluminum infiltrates the bone marrow, targeting the precursors of our red blood cells. It blockades heme synthesis by displacing iron at the active sites of critical enzymes like ferrochelatase. This explains the failure of iron therapy. The iron is present, but essential enzymes are disabled. By weaponizing the iron transport network, aluminum dismantles the neurological, the skeletal system, and hematologic pillars of the body. Detecting this metal is analytically complex because free aluminum ions do not exist at physiological pH. Standard chemistry panels cannot see them. The gold standard for measurement is inductively coupled plasma mass spectrometry, or ICP-MS. The process begins by atomizing the blood sample in an argon plasma torch burning at 8,000 Kelvin, hotter than the surface of the sun. The mass spectrometer then separates ions based on a specific mass-to-charge ratio of 27. This search faces polyatomic interference. Inside the plasma, argon bonds with carbon to form a complex weighing 27 units. To resolve this, the lab uses a helium collision cell. Larger argon-carbon artifacts crash into the helium and drop out, while aluminum ions pass through safely. The analytical process requires isolating the specific aluminum ion from a sea of identical weight molecular artifacts. It proves that the metal is as difficult to track in the laboratory as it is in the body. The greatest risk to an accurate diagnosis occurs before the sample ever reaches the machine. It is a matter of pre-analytical environmental contamination. Aluminum hides in ambient laboratory dust and standard hospital supplies. Standard collection tubes contain rubber stoppers that leach the metal directly into the sample. To mitigate this, phlebotomists must use specialized royal blue top trace element tubes and plastic cannulas. They must also discard the first 5 to 10 milliliters of blood to flush away any needle-derived metallic fragments. The laboratory maintains a strict total allowable error of plus or minus 20%. Delta checks are used to halt results if a patient's level shifts significantly within a 48-hour window, triggering a search for contamination. In trace metal pathology, the most sophisticated mass spectrometry result is worthless if the protocol failed to control for the dust in the room. Clinical interpretation depends on established thresholds. For hemodialysis patients, a level below 20 micrograms per liter is the safe target. Levels exceeding 60 signal a risk of bone disease, while a result over 100 indicates impending neurological toxicity. If baseline results are inconclusive, clinicians can evaluate the total skeletal burden using the deferoxamine infusion test. Treatment begins by removing all external sources and initiating chelation therapy. The drug deferoxamine is administered to strip the aluminum from the bone matrices. This treatment is governed by a critical velocity constraint. Infusing the chelating agent too rapidly pulls massive amounts of aluminum from the bones all at once. This flood can overwhelm the vascular space and rush into the brain, triggering acute dementia or life-threatening seizures. Given these risks, diagnostic stewardship is essential. Aluminum panels should be reserved for those with compromised renal function and specific symptoms, not for routine cases of age-related dementia or standard iron deficiency. Aluminum illustrates the strict chemical boundaries of biological life. It requires absolute diagnostic discipline to detect, and extreme therapeutic patience to slowly extract this alien element from the human architecture.